Hi, I'm Ron Zimmett of the Daytona Beach law firm Zimmett & Quarles. I'm a trial lawyer, and I've been the risk management consultant for Negley Associates for many years. This is part of our ongoing series of monthly risk management tips for community mental health centers. The topic this month is the single most important thing you can do to reduce the risk of suicide malpractice. In fact, it's not just the single most important thing you can do to reduce the risk of a lawsuit, it's also the single most important thing you can do to provide quality care and reduce the risk that a patient will commit suicide on your watch. At Negley Associates, we've had over 30 years of experience dealing with actual lawsuits against community mental health centers. Lawsuits can be an opportunity to learn about the type of actions or omissions that result in injury to patients. What we've noticed is that the expert witnesses retained by plaintiffs in suicide malpractice cases almost always are critical of the suicide risk assessment done by the defendants. I should acknowledge that we see a skewed population of cases. That is, we only see the cases that result in something bad happening, either death or injury from an attempted suicide. If something bad doesn't happen, lawsuits don't happen either. Our thought is that the better the assessment, the more likely it'll be that the healthcare provider will decide on the best intervention strategy. And I don't mean that there should be only one assessment, because assessments should be updated periodically as the patient's circumstances change. Some expert witnesses are now asserting that assessments should be done in a structured way. Basically, the idea is that the person doing the assessment has a checklist of steps to complete to be sure that the assessment is thorough. Researchers and experts in the field have suggested a variety of different kinds of structures. One suggested structure is described in the Harvard Medical School Guide to Suicide Assessment and Intervention. The authors suggest a 5-step procedure. First, identify predisposing factors. Second, elucidate potentiating factors. That is, the sufficient conditions that make a suicide possible. Third, conduct a specific suicide inquiry by asking questions. Fourth, determine the level of intervention. And fifth, document the assessment. Predisposing factors include the diagnoses of major affective disorders such as bipolar disorder and major depressive disorders. Also, alcoholism and schizophrenia. Sufficient conditions include the wide variety of suicide risk factors such as family history, personality variables, the presence of firearms, and the long list of other factors. I do suggest that a checklist of these factors be available for anybody doing an assessment. It is extremely difficult to remember all the factors without a written checklist. The questions to be asked during a specific suicide inquiry include whether or not a patient is having suicidal thoughts and a plan, but should not be limited to these questions. I often see medical charts that only document these questions. The level of intervention should vary depending on whether suicidality is based in an Axis I disorder. Documentation, of course, should be thorough and could include discussion of a risk-benefit analysis for the decision as to the appropriate intervention. For now, this is Ron Zimmett. I appreciate your listening. For a lot more information, stay tuned to our monthly series.